St. Peter, I'm here. I am finally here, just outside your great gate. Well, let me tell you just all the good things that I've done on earth. Let's see, I've helped a bunch of homeless people with diabetes. I help them live healthier lives. And let's see, I work with lots of children with asthma. I taught them how to use their inhalers and how to take their medicine and what else? And the elderlies. Yes. I help them. I help them with their medicine so they, to prevent drug interactions. So, St. Peter, can I please enter your pearly gate, please?
Where's the data?
The value of data collection and documentation is, I think it's pretty simple. Unless you document things, you really probably shouldn't do it. We need data. I need data to continue to support these programs. Nationally, we need data that shows cost savings, shows increased better outcomes, better clinical outcomes. Without the data, we don't really know what we're doing, and we can't tell the story to anyone else. So it's absolutely imperative that we document what we're doing, provides data for research opportunities for our faculty. But most importantly, I think, is, again, unless you document it, you really don't have any good proof or any good story to tell to anybody about how these programs work, what their outcomes are. And so it's an absolutely critical piece. The safety net practice environment really allows us to practice at such a high level and show such great clinical outcomes as well as financial outcomes that it serves as a platform for me to be able to go to the medical school dean, to go to the county supervisor, to go to other people that are influential people, policymakers, and actually demonstrate that this level of pharmacy practice will result in these kinds of outcomes, in these kinds of financial savings. And it's a very easy story to tell.
The clinical pharmacy program actually has allowed us to identify potential adverse drug effects and adverse drug effects, so that we have a lot of patients that we've seen that have had drugs prescribed that there were potential interactions, or there were interactions that were caught by the clinical pharmacist. And the other thing is that when you look at the data that we have done and collected here over the years, it's very clear that the health outcomes at this clinic, where there's diabetic, hypertensive, asthmatic patients that are homeless, is actually very good. In fact, this clinic, JWCH has 6 clinics. This clinic, because of clinical pharmacy, has the best health outcomes control for diabetes, and it also has the highest provider productivity. And that says a lot, because when you have homeless patients, which are in and of themselves more challenging because they've got substance abuse, mental health problems, social issues, nowhere to live a lot of times, you'd think that those patients would be the most challenging and poorly controlled. But the fact is, because clinical pharmacy is here, like I said, more patients are seen by the providers because the harder ones go to clinical pharmacy, and health outcomes at this clinic are better than our other 5 community health centers. In order to sell the program, you have to have data measurements available to actually be able to sell the program to administrators and sell it back to physicians. Buy-in is very important, and the best way to get buy-in is to have data to support what you're doing. It creates trust, it creates buy-in. And so what we've done is actually set up a system here where we monitor patient outcomes through our PECS registry. It tells us how well our diabetics are controlled. in terms of hemoglobin A1C. It tells us the number of medications they're on. For our hypertensive patients, it tells us how their blood pressure is doing. For our asthmatics, it talks about how, it gives us information about how well they're being controlled with the use of steroid inhalers or anti-inflammatory medications, things like that. So we use that data, compare it to patients that are not accessed in clinical pharmacy, and we have found that without question, the data is much, much better for patients that have had clinical pharmacy services. We've been able to take that data, looking at the people that have had services versus the comparison group, those that have not had clinical pharmacy services. And by that I mean patients that have not had medication management services with the clinical pharmacist. And the data is amazing.
The pharmacy program, as I mentioned earlier, we started with one, and we found that it was so efficacious that not only did it help the patient, it actually was improving the care of the patient. So over time, Queen's Care, through grants to Queen's Care Family Clinics, expanded the program, and I think there are 3 clinical pharmacists. Queen's Care Family Clinics have 6 clinics, and they cover the clinics part-time because of only 3. If the thought is to add a 4th so we have more coverage, because the program is excellent, and our number of chronically ill continue to increase, especially with diabetes. And with the tracking, Queen's Care Family Clinics now have an electronic health record 3 years in, so the data we're able to track with our providers and our clinical pharmacists are absolutely fantastic. And we can track hemoglobin A1C, lipids, everything else that deal with the clinical pharmacy program, and the results are truly amazing when you consider that the current literature, 1 point drop basically saves the system $1,000 per year. And when you drop hemoglobin 1 point, we've seen drops of 3, 4, 5, coming from 10, 12 down into the 7, 8, or 9 range, which again proves that the program works. And we didn't see that because we have data before, when it was only the provider. We didn't see those kind of results because they didn't have the time.
I think when developing a measurement process, the biggest challenge is time. You want something that's efficient, that's quick, and you want to do it right when it happens, because if you wait until later, it's probably not going to get collected. And so ideally, your measurement tool should be automated. It should be available to you at the point of care. If you can't document at the point of care, document right after, because if you don't, again, you don't get into a electronic format of some sort, the likelihood of collecting it is probably not going to happen. So I think those are probably the most important things. Maybe the third, I think, probably overriding important goal is that as you develop your data collection method, you need to make sure you're aligning your goals with national standards and you're collecting those same elements. If you do that, you can actually get other members of the healthcare team to help collect the same information, because we're all interested in the same outcomes. Clinical pharmacy service needs to collect everything that reflects patient outcomes, particularly health outcomes, because we want to see the impact of our care on patients' markers of disease control. Those are the A1C, blood pressure, cholesterol, those sort of things. We also want to check measures that relate to medication errors. So anything that could be a potential adverse drug event or an actual adverse drug event. We also want to be mindful of the time we spend with patients. So the number of patients that we see, the amount of time if possible, that would be great, because we want to see how that offsets the amount of time that patients have to spend with their physicians. In the sense, the time that we save physicians from having to spend extra time with these patients. We want to log the kinds of changes we make to drug therapy. So a big part of our job is to identify those drug-related problems and then to identify solutions, implement those, and then follow up patients to ensure that they receive a good outcome. So we want to track every piece of that process and make sure that we know what it is that we're doing in terms of, are we adding more drugs more often, are we finding side effects more often, are we discontinuing drugs, that sort of thing.